Okay. May we then turn, please, to item 5, which is the update on right care and the shift to value-based healthcare. I'd like to invite Tim and Muir to come and join us. Can I just say thank you on behalf of the whole board for taking the time to come and talk to us this morning. Paul will in a moment introduce the theme. Can I just say we have limited time, so without wishing, of course, to cut across anything that you might say, some really highly focused points would be valuable to us because the board are very interested to pursue the ideas with you. Paul.
Thank you, Malcolm. My introduction will be very short and sweet. The board is, of course, already familiar with the Right Care programme from previous discussions, which have highlighted its central importance both in creating major improvements in outcomes, which lie very much at the heart of what Right Care is all about, but also at the same time delivering a very substantial proportion of the efficiency gains that we're committed to make and indeed need to make in order to live within the resources we've got available in the spending review. So it's a programme which is absolutely central to our success as an organisation and the NHS's success beyond that, and therefore it's right that we take this opportunity to have a proper review of it. It works hand in glove with similar programmes led by NHS Improvement, which focus on eliminating waste and tackling variation in the delivery of services by providers, notably, of course, through the Getting It Right First Time initiative, which should, by the way, Tim, win the award for the most sonorous acronym in the public sector, GIRFT, which I suspect probably sounds better in my native West Country than it does in London. We're making good progress with the rollout of both programmes across the country. Following our decision recently to ramp up Right Care from a cottage industry to a fully fledged national programme with commensurate resources, it's now engaged actively with every health economy in the country. Right Care is also being adopted by our specialised commissioning teams at national and local level as a key pillar of their efficiency plans over the next few years. And we are, so to speak, injecting Right Care into national efficiency programmes in areas such as continuing healthcare and medicines optimisation. So its reach is rapidly growing. I'm really pleased to welcome into the audience today a number of members of the Right Care team who are with us today, particularly as it gives us an opportunity to express on behalf of the board and others our appreciation of the enormous and very valuable work that they are doing, and I would very much like them to pass that on to the quite numerous colleagues who aren't with us today. You are doing a splendid job in an area of enormous importance. As the paper points out, both Right Care and GIRFT will be the key to the success of STPs going forward, not least because in most places STPs are best placed to oversee the resulting reallocation of capacity, which is one of the biggest challenges facing the programmes, but also a major opportunity, particularly in the context of the operational pressures we'll be discussing a little later. But we're at a crucial point in both programmes where great opportunities need to be translated into effective implementation on the ground if the potential benefits, both clinical and financial, are to be realised in practice. So I put it to you that our question today is not so much whether the programmes are good concepts, or even whether they give us the right scale of opportunity. On both of those questions, there is wide consensus. The critical question is how we capture those opportunities at the pace required by the challenges faced by the NHS over the next few years. Both Right Care and GIRFT rely critically on a deep and evidence-based partnership between clinical leaders and managers from a range of functions, including, of course, finance, which is why Bruce and I have been heavily involved in sponsoring the Right Care programme within NHS England. But it's also why we've invited two of the clinicians who've been central to the development of these programmes to come and inform our discussion by sharing with us their perspectives on the best way to capture the enormous opportunity on offer. Muir Gray is an Oxford professor, but we won't hold that against him, a former Chief Knowledge Officer of the NHS, and an internationally acknowledged expert on value-based healthcare with a 45-year track record of leadership, innovation, and prolific authorship in this area. More specifically, he is, of course, one of the founding fathers of what's now become NHS Right Care, so we have him to thank for the programme that we're now taking forward. Tim Briggs is a leading orthopaedic surgeon based at the RNOH, with a similar track record of national leadership in this field. In 2015, he was appointed National Director for Clinical Quality and Efficiency, and he was a key contributor to the efficiency review led by Lord Carter. The RNOH itself was the cradle of the GIRFT programme, with Tim, I would say, as a somewhat unlikely midwife. So we're again indebted to him for the groundbreaking work we're now benefiting from. So without more ado, welcome Muir and Tim. The floor is yours.
The mission of Right Care is to get better outcomes for individuals and populations with no more resources. And I use the word resource because it's not just money. It could be the time of staff, it could be the time of patients, it could be imaging department capacity, it could be lab department, it could be the number of beds, as Tim will discuss. And there's been in the last month a huge surge and increase in value-based healthcare. 7 papers in the Lancet on overuse and underuse and the need for high value. 2 BMJ editorials, and a report by the OECD, chaired by Jeremy Hunt, saying that $3 out of 10 are not producing value for the population served. Not specifically, obviously, UK, but we're in the lead in the thinking and the practice. Now, we use the word value as distinct from efficiency. Efficiency is outcomes over costs for the patients treated, but value also includes allocative value. Have we got the right distribution of resources to cancer or mental health, or within cancer to breast or cervix or lung? And secondly, the use of resources has to take into account the underuse of high-value interventions, like the treatment of atrial fibrillation with warfarin, and the overuse of lower value or zero value or negative interventions. So it's about a shift in resources. We have 20 delivery partners working with the CCGs and increasingly with the providers and the clinicians. A couple of examples. In Bradford, they've improved not only the practice but the outcome of cardiovascular disease and released £1.6 million for reallocation. In Croydon, working closely with Tim's team, the same for musculoskeletal. Again, £1 million released fairly simply for reallocation. We don't like the word savings, actually, unless someone's actually overspent. We find the clinicians are turned off by the word savings. So we're looking all the time for the word value and reallocation. And there's terrific scope still. A couple of examples. Imaging is going up 12% a year in many places. In one London hospital, 22% increase in CT and MRI. Huge increase. Now, what is the added value of the last 10% of that? We've also got a project going led by a terrific young doctor called Ben Goldacre, who you may have seen in television or read in The Guardian, where he's developed a browser-based means of looking at how every practice operates. And he just picked one drug, and if every GP took the equally effective, lower-cost drug, it would free up resources for 350 district nurses and 350 care assistants. A district nurse plus a care assistant, 76,000 is our basic unit of high value care. So huge changes from multiple small changes. So looking to the future, how do we see it? I think we see it still as largely a culture change. I mean, we're working in management with the teams here, part of the teams here, but it's changing the way the clinicians and the public think about the balance of benefit to harm. Key to this is the way individual patients are informed about the risks as well as the benefits of harm. Modern medicine is fantastic, what I've seen happen in 50 years since I went to medical school, but all healthcare does harm. And do the patients, do they really, really understand the risks as well as the benefits? The answer is not yet, but we have a shared decision-making service which we should increasingly automate, and no one should have a significant intervention without being fully informed about the risks as well as the benefits. Secondly, we will continue work on variation, and we want to do this much more light touch. This is the NHS Atlas, which is produced on the principle of OMG. Oh my God, what's going on here? I mean, we don't know what right is for many of these issues, and the third Atlas is upstairs for you, I think. But we want to move much faster now. Take skin disease. It's a small budget. £2 billion a year. 3 maps would alert the whole of the health service to think. So we're moving much more to think of different ways of getting variation. Secondly, programme budgeting. And the Programme Budgeting Board will be chaired by Matthew Cripps. And we really want to see people, I mean, there's a 1.9-fold variation in spend in mental health. 1.9-fold, that's a lot of money. And I can't find any, not only can I find no good reason, but I still feel the CCGs plus specialist commissioning are not really addressing the issues of what we call between programme allocation. And that's going to be a priority for Paul's team and the other teams in the next year. Thirdly, systems. So once you get into the programme, we need to forget about primary, secondary, tertiary. I mean, they're vitally important, but they're bureaucracies, very important. But we need to go for population-based programs and population-based systems. Is care for people with atrial fibrillation better in Liverpool or Manchester? Don't know. Is care for people with asthma better in Somerset or Devon? We know a bit about outcomes, but not related to the cost. So we've got to shift to a vertical programming as a matrix. And that's part of the work we're doing, and atrial fibrillation be a good case study in that. We could probably prevent 5,000 strokes and 10% vascular dementia with no more resources if they manage atrial fibrillation as well as they do in Bradford. So these are the sorts of challenges we're facing. Then the issue of culture, and this is where Tim and I work together, as many of you around the board will know from your management experience. Culture eats structural reorganisation for breakfast, lunch, dinner and afternoon tea. And we see this largely as a cultural programme. Tim's work is also culture change too. So we're thinking of how do we really influence how large numbers of people think. That requires a common language. Does everyone use the word value and efficiency in the same way? The answer, no. Who do we have to train? Probably down to about 8D. People need to think. If we're in the military or if we're in big business, then we would move into a much more systematic approach to culture change, and that's one of the things the board might like to ask about. In all of this, we've been working increasingly closely with the terrific work Tim and his team are doing, so I'll pass to Tim now.
Thank you very much. Thank you, Peter, for those kind words, actually. So I know that some of the board are really unsighted on me, really, and on what we do, so I thought I'll just over the next 2 minutes tell you where we started from and exactly where we're going. So I'm an orthopaedic surgeon based at the Royal National Orthopaedic Hospital. I've done 26 years at the Coalface in a tertiary referral hospital, and I could see what was coming down the track because I was also medical director at the time. We've got an ageing population who are living longer, we all know that. People want to remain independent, and therefore the burden of MSK disease is getting greater every year, and we were seeing referrals climbing at 7 to 8% per annum. And if you look at orthopaedics, we represent 33% of the surgical workforce, 25% rising, 26% now of all surgical interventions in the secondary care sector are in my specialty. So we're massive players in the game. And what I was seeing was the patients coming through to us that maybe hadn't had the best advice, hadn't had really the best outcome. And so I wrote a report which was published in 2012, focused on improving quality, improving patient safety, and with that you would squeeze out unwarranted variation, reduce complications, and actually from that you get better outcomes, and actually savings would fall out the bottom. That's what I thought. So I produced this report, and Bruce was very kind in getting me £200,000 plus VAT. He never forgets, lets me forget about the VAT. And with that, we've got a team of 5 together, and we got a unique data set on every single trust in England, or 12 different sets of data, based on quality outcomes, actually. And then the great strength of what we're doing, it's clinically led, and it was a peer-to-peer review, and then I went out with my team, having sent the data to every hospital, went to visit every hospital. So in the last 2 years, I've been to every single hospital in England, Scotland, Wales and Northern Ireland. So no one can pull the wool over me. I know exactly what is going on out there. And the idea was to have this conversation with clinicians and senior management teams about what they were doing, how well they were doing, and if they weren't doing things well, what we could do to improve it. And what we found out there is that there was significant variation. There was some excellence in some places, and there is no doubt there was massive scope to tackle this variation. I'm just going to give you a number of examples which I think will demonstrate what we can do and how it can help you. So if you look at the deep infection rate for hip and knee replacement across the country in England, just in England, it varies from 0.2% to 5%. And there was one hospital in London that we went to where at the time they had a bit of a problem, and it was 15%. Now, it costs, on average, to treat an infected hip or knee replacement anywhere between £75,000 and £100,000 by the time you take into account all costs. Now, if we could reduce that infection rate, which we can do by setting up certain standards, ring-fence beds, teams in theatres, etc., to less than 0.5%, you would save the NHS every year between £250 and £300 million. That means you could do between 40 and 60,000 extra joint replacements at no extra cost. We also found arthroscopy rates in patients over 60 who then go and have a knee replacement within a year, the variation was very significant. We also found surgeons doing low volumes of procedures, and if you're doing low volumes, your outcome's not as good, which means the patient will be back earlier for revision. And if you're doing low volumes, you bet in what we call loan kit costs to do these procedures, and we found loan kit costs around the country per trust was varying anywhere between £250,000 a year to £760,000 a year. Absolutely crazy. And when you drill down to what surgeons are doing, 81% of surgeons doing revision knees replacement, which is complex and expensive, were doing less than 10 a year. In half knee replacements, we know you've got to go up a learning curve to do about 20 a year to get up that learning curve. The commonest number being done was 1, followed by 2, and 75% of the surgeons were doing less than 10 a year. We also looked at litigation costs. In orthopaedics, it's going through the roof. We're the most litigated out of all the surgical specialties. And we looked at the data set for 2011 and 12. If you go back to 2003-4, we paid out in 1 year £39 million for litigation orthopaedics. In 11-12, it was 187 million and is climbing at the rate of 30 to 40 million a year. So what we did is we took the data from 11-12, we drilled down to, well, what is the cost in England of a patient's cost of every intervention, what litigation cost was it? And it was £54. But we went to trusts around the country where it varied in that year from 0, and also trusts where for every single case it was £154. And at no point had there been any discussion between management and clinicians to address these issues. And what we found was that if you were a high outlier, it was a recurring problem. So we found that we could do a huge amount in terms of what we could do. And what's interesting is that since we've been round, if you look at the litigation data now, which I've got, and we started our visit in 2013, 13-14, orthopaedic claims climbed by 9%, which is what I would expect because we were going around the country at that time. But 14-15, they've dropped by 5%, and 15-16, they've dropped by 9%. So a real evidence base that what we're doing has an impact, and it's because it is peer-to-peer clinical reviewed. So after that £250,000, we were then able to, from Department of Health, to get 2.55 million, which has allowed us to implement the findings in orthopaedics. What that means is we've got new data sets. We're going back out round to every single trust in England. We've got comparison reports, seeing what they're doing, how they've moved the dial, and there's some really good evidence there that trusts are already doing. Two examples. One is the Homerton. It was a bit of a problem 2 or 3 years ago, and they've got a completely new set of young consultants there. They are moving the dial very, very quickly in terms of their choice of implants, subspecialising, doing what's right, using the evidence base, etc. Another example is Ashford and St Peter's, where they've moved the dial significantly since we were there. So we will also be producing dashboards, which will have all that data set, which we will get trust to refresh, and that will form part of the model hospital dashboard and the portal. So every trust will be able to see what it's doing, and then we want to allow trusts to compare their outcomes with other trusts. We also are able to look at another 11 surgical specialties. So this is just what's coming your way at the moment. And of those, we've appointed 11 national clinical leads, like myself, I hope, who are going to deliver using the same methodology I have done, the data sets, going out there, peer-to-peer review, and the solutions actually become obvious, and therefore there'll be local reports and also national reports. And just give you an idea of the calibre of people that have now become forward as these national clinical leads, the current president of the Royal College of Ophthalmologists applied for and got the GERFT lead job. That's the sort of calibre of people we've got, and my team, data mine, etc., are brilliant. So the team is now going up from a team of 5 to 122, because we're able to get another £60 million from the government on November the 8th last year. And so we're now going to look at 30 specialties, which covers 92% of all the work that goes on in the provider sector. So where are we at the moment? So we've got general surgery out on the road. John Abercrombie's my national clinical lead. The national report, I've seen the first draft. It is going to be a wake-up call, I have to say, for clinicians. It is going to be a wake-up call for the NHS. Behind that, we've got spinal surgery. That is going to be a massive wake-up call for all of us in terms of using the evidence base on what we do, and a lot of what goes on in the spinal surgery about injections and some of this instrumental fusion, the evidence is not great. And there was a national spinal registry mandated 6 years ago by CCGs. To date, only 15% of the total data has been inputted. 80% of spinal surgeons do not know their infection rate. We've also got vascular surgery out there. We've got neurosurgery. Those visits have happened. Those visits have taken place. And again, the national report is going to be a wake-up call for all of us in the provider side and also for the NHS. And let me give you some examples. So if you have your gallbladder removed and you have it done in any trust in England, your readmission rate back into hospital at 30 days varies from 0% to 12%. If you're unfortunate enough to get a cancer of your lower bowel and you need a stoma, your stoma rate after 18 months varies between 25 to 78%. If you have your spinal surgery and you ask your surgeon, what's my infection rate, they don't know. If you have an oral cancer of the mouth excised, your readmission for a further operation at 90 days varies from 8% to 80.56%. And if you have your tonsils taken out, you'd have thought we'd get tonsils right, your readmission rate at 30 days varies from 3.6% to 27%. So huge variation, and something that I think we can really tackle and do something about it. And if you look at neurosurgical procedures and you have what's called a ventricular peritoneal shunt, your revision rate at 2 years varies from 8% to 44%, and your infection rate from 0.2 to 6%. So where are we now? So we've got all this data. The national reports will be produced, and they will actually change practice. And then I'm now sitting with NHSI, have the mandate from Jim Mackey and also with Patrick Carter to deliver this programme, which means using the data and not acting on the data now in trusts is no longer an option. And we are going to hold people to account to deliver that. I think it is a real opportunity for us all to make the changes that we need to make sure we improve quality, reduce unwanted variation and complications, and with that the savings will drop out and allow us to do more work through our bed base that we currently have. I also came across real good pockets of really good care where it's not really widely disseminated across the NHS, and if I may, I'll just give you two examples of that. So in Fife in Scotland, they have a real problem with their admissions of surgical patients. So they put the general surgical consultant on call as the first person to see a patient after A&E. Guess what happens to their admission rates? Drop by 30%. If you go to the Luton and Dunstable Hospital, which is where I live, and that's where I'll go if I'm poorly, I assume, they had a problem with their medical admissions. They hit their A&E targets. Why? Because they've addressed the problem. They've put senior consultants behind the A&E department who see these patients, and their admission rates have dropped by 30%. So there are massive ways that I think we can do to actually streamline our system and use our bed base of 129,000 beds very much more effectively and help the NHS to continue to provide timely, effective care for our patients. Thank you.
Fantastic. I think two really well-focused and hugely informative presentations. Let's open up discussion around the table. Please, Noel, start.
Gents, thank you very much. As you know, I'm a great enthusiast for all you're doing in improving our cost, our quality, and our outcomes around our triple aim. But having spent much of my time in another industry trying to do something very similar, you quickly realize the distinction between shining a light and embedding it in a culture where it becomes a way of life and good working practice. What are you finding at the moment about the way we can build this into continuous improvement in the way we run our health system? Are we getting closer to embedding it into the culture?
Let me answer first quickly on a little bit more to the commission end. The spectrum, we don't know now. We're one team. We're one team. So, as I say, my own view is it's culture, and I think there's about 500 people per million population, most of them clinicians, who need a different mental concept. For the last 20 years, it's been evidence-based decision-making, quality improvement, both absolutely essential, but they've now got to take responsibility for, in the words of the Academy of Medical Royal Colleges, the stewardship of resources. If we want an NHS for the next generation, the clinicians have to take responsibility for getting good value use of resources. And this requires not circulars or documents, it requires us to train people to think in a different way. And that's our plan for the future. So we haven't made the move to large scale. People are still looking to, will the commissioner sort it out? Will the medical director sort it out? But everyone who orders an MRI or a second rheumatoid factor test or whatever has to feel I'm committing resources that might, in the words of the Royal Academy of Royal Colleges, delay or deny treatment to other patients. It's not the taxpayer we're worried about, it's other patients. So I think we see the need for a major cultural thought leadership, you would probably call it in industry. Tim?
So what I'd say to that is I think we will drive the dial, and I think it's going to happen. And the reason I say that is twofold, really. One is we now have all the Royal Colleges, all the specialist societies, everybody behind this, and they see it as the serious game in town because it's peer-to-peer review, clinically led, and it will deliver the change we need to make within the provider side. And crucially, the data is robust. The first thing I was told always, well, Tim, the data's not great. And actually, by the time you have 12 different sets of data, it tells a really good story, and people, the light bulb goes on and they say, well, crikey, we've got to do something about this. And the dashboard that we've developed in orthopaedics, we'll have one for each specialty on the Model Hospital website, and the portal actually will drive the change, especially when you let providers look at other providers. No one likes being in the bottom 25%, and that will make a big difference. So I think the fact that we're going to have robust data, that will drive the change. And the fact that these are peer-to-peer review, and just going out now, when I'm going back out with all my follow-up data, and I come up comparison reports, everybody's at these meetings, senior management team are all there, everybody's buying into it, and they know that there's another 29 coming behind me. And they now know through NHSI and with the work you're doing in NHSE, actually doing nothing with the data, that ain't an option anymore. But I think one of the things I think we need is we need much more closer working between management and clinicians. Wherever I went, where it was top-down management, ain't working, it's not going to work. Everybody just gets disenfranchised and just gives up. But actually, where you have clinicians and managers working together, shoulder to shoulder, as I call it, then that is the way to live it. So I think we are seeing significant change. I've got lots of evidence from hospitals where they've moved the dial. Yeah, I think they are up for it, up for the challenge.
So, I think this is great. It's about 2 years since we met, and I think it's fabulous, and Matthew's in the audience, and we should pay credit to the work that he's done to build RightCare. But what I'm intrigued in, and Tim particularly, is we're looking down the vertical sort of specialties, but there must be similarities across horizontally. So the question, I guess, is why do we get this variation, and what systemically do you think needs to change in order to give us better outcomes and better ability to drive out better outcomes?
Okay, so I think it's multifactorial. I'd say that, and I think if you go back to the early 2000s, the driver was 18 weeks. And that was the sole driver of where we were spending our money, and actually that was the target. And therefore, quality and outcome was not an issue that was looked at. And I think now the focus with the way we are in the situation now has to be a real focus on quality. And I think as a profession, we've been slow in the uptake, but I think we now got the bit between our teeth. And I think what's shown from that is the support we've had from all the colleges and the associations. And I think we will now see with the good evidence base that we have for each trust and with each specialty as we drive it, that actually we will see the squeeze out of unwanted variation. But I think it also calls into question the way we train.
Yeah.
And I think we've got to look right back at that. And if you're a surgeon, because I think you ask a very good question, why is there such a difference? So I think we've got to, and the mandate now for HEE includes working with us with our data sets to make sure that trainees are placed within where the outcomes are great. So great service is usually great training in my experience. And I'm still a training program director with 60 trainees. Sending them to training opportunities is not always the best thing because they may pick up bad habits. So I think we've got to go right back to the way we train in order to actually embed this as we move forward and make sure it's as business as usual for the next generation coming through, actually.
I think we've also, some patients are institutionalised, all professionals are institutionalised. They've mostly worked in the one hospital or one health centre for 25 years. So we see the SDPs and the academic health science networks, if we can get them at that strategic level, get the map on the wall. So we need to get people out of their bunker, and in the way we've been doing, just see what they're doing down the road. They haven't a clue.
Thank you. I wanted to ask about the patient dimension. So you said at the beginning that our aspiration is that nobody should have an intervention without having had a properly informed conversation and making a properly informed choice. And I was interested in how this data is contributing to that. Because if I'm thinking about, a child potentially having their tonsils out, and in one place there's one chance in 4 they'll be back in hospital again within a month, and in another place there's 3 chances in 100. I mean, that's a massively different conversation. And I suppose what we know is that another real driver for change, as well as peer-to-peer and manager to practitioner, is patient to practitioner. And you only need a few patients asking you about your complication rates to really begin to stimulate changes in behaviour. So I guess my question is, to what extent is this data available to the public? To what extent are we helping them use it?
I'll just comment perhaps in the medium rather than the message. Bill Gates said the key question for any organisation in the digital age is what is the function of the human being? What do we want nurses and doctors to do? And it's not to give information. We know they're not very good at it, and the consultations are so emotionally highly charged, it's very difficult for people to remember what happens. So I think last month, or the usual figure is 35 million visits to NHS Choices and a shared decision-making programme in there. So we need to work out new ways of using digital before and after the consultation and not rely on the face-to-face consultation alone. It's just not working. But we have now, we've got the message and we've got the media, and we need to make a bit of a jump through general practice, through the information systems. But I think that's what we see now, is we need to move from what's the matter medicine, as someone said, to what matters to you medicine. What actually is wrong with you that you think a knee replacement would help? Usually it will, but there may be quite other solutions that are there. So that's the plan, using digital resources to bring the patient, the citizens, fully involved.
Do you want me to? So I think we should probably go further than that. So we're going to have this dashboard showing data, and I want to get it up and running. I want to make sure it's robust. So we get it across 30 lines of different specialties, which has been, as I say, 92% of what's going on there in the provider sector. And I've been keeping the Patient Association, Catherine Murphy, involved in information about this throughout. She's been incredibly supportive, I have to say. And once we've got the data robust, why can't we let CCGs and patients see it? And that's going to be the question. And I think that'll drive the change even further than we've driven the change now. And I think eventually, when in terms of transparency and transparency agenda, I think that's what will happen. And that's what I would aim to do once we've got things robust in place and everybody's happy with their data set.
If I might just jump in again, I think the question is not why can't we let CCGs in the public, it's what possible justification could there be to not allow that to happen. And whereas in an ideal world we would clearly want every piece of data that's put in the public domain to be completely robust and reliable, in practice I think in a number of different spheres, one can see that the knowledge that data is going to become public is a massive stimulant to people putting in the effort to make sure it's right.
Yeah.
So I would just encourage you. I think it's fantastic, and the sooner the better.
Good, thank you. I've got John, Michelle and Bruce so far on my list. So, John.
Mayor, you mentioned warfarin briefly in passing, and I know you're very interested in atrial fibrillation, which more than 1 million people are at increased stroke risk because of. In our city, last year, more than half the people with AF who presented with a stroke were not anticoagulated, so there's still a lot to be done in that domain. And in fact, because of publicity, more and more people are being put onto anticoagulants. However, there is a big debate about what anticoagulants. So warfarin is the standard, but there's huge variation in who uses that versus the direct acting oral anticoagulant. That has an importance for us as a board because on a year-on-year growth of about 100 million a year in expenditure, there is actually a credible academic debate about whether in fact warfarin used better by personalising the dose and by giving self-testing is actually at least as good as DOACs. And so we've got an argument not only about how do we get people to anticoagulate, but also which anticoagulant we use, because clearly to make best use of resources, we should be using the cheaper option. I've got in front of me the open prescribing graph, which shows a 7-fold variation across CCGs in the ratio of warfarin to DOACs, rising from 9% to 60-odd%. So is this an area that Right Care might address, and what ideas do you have on that?
Well, this is moving from primary, secondary, tertiary to people with cardiovascular disease, and within that, people with heart failure or people with rhythm disorders. So it's a matrix, not one or the other. But as we move towards a systems-based approach, and this is one of the ones with Public Health England, we've set up a system. Simply putting guidelines into a lot of bureaucracies won't solve the problem. The bureaucracies are very good at linear tasks, like the fair and open employment of people, but this is a non-linear problem. So we are about a third of England is now signed up to what a common spec, and that would mean within the resources available, what are we going to do? A key issue here is the centre, us, not telling people how to do it. But this is classic military. Strategy and operational is different. So we need to decide what is the right thing to do, and I'll wait outside the meeting and get more information from you. Then we meet the system spec people. Locally, it's GPs in Bradford, it's a haematologist in Essex with nurses, and it's a cardiologist in North London. That's a local operational thing. But we, NHS England, NHS Improvement, we have to say what it is we want to achieve. So that would be a perfect example with no more resources. Or if we make a decision to increase resources, shall we shift money from another part of the cardiovascular budget because there are resources available in there of lower value than, I always use the word vascular dementia as well as stroke, because I think there's 10% of vascular dementia can be prevented by the good management of atrial fibrillation.
Michelle.
Thank you very much. What would your message to the public be about why this is a good thing rather than something to fear?
Well, I maybe 200 times in the last year. I'm a bit more in town halls than hospitals. I like to meet with clinicians and patients and the public. And I show them, as a wonderful graph, the most important picture in medicine is Don Abadian's graph. As you put money in, the benefits go up and then they flatten off. Harm goes up in a straight line. The more healthcare we do, the more harm we do. Quality means benefit goes up and harm goes down with this shape. So in the middle, if John bends his elbow and this way, there's a J-shaped curve, a point of optimality, Don Abadian called it. And I asked the public, where do you know healthcare that's gone beyond the point of optimality? And from the audiences, the same things come out. Polypharmacy for older people, over-intervention in the last year of life. This is not to do with the money. Sometimes chemotherapy, 8th and 9th round chemotherapy, sometimes elective surgery, wonderful though it is. Too much imaging. So the public understand this. We need to get our story clearer, and for both the individuals and the populations, to make clear that all healthcare does harm as well as good. And we need to treat you all as adults, and we need to tell you that doctors usually use less healthcare than non-doctors. We know it goes wrong in the best of hands. Cataract operations, 1%, 1 in 1,000 goes badly wrong. That's, now if you're housebound, then you run that risk. But if it's just picked up in the optometrist and you're put on a waiting list, you need to know that's the option you're facing. So I find the public actually, if I'm in Barnet Town Hall or somewhere, I mean the public are aware of this, but we haven't articulated it clearly enough.
So what I'd say to that is that when patients come to see me, They just want to get better, and they want the best possible care. And we try and achieve that at the organisation in which I live. Now, what I want to see out of this is if someone goes into hospital, either for a prostate operation or a cholecystectomy or a hip or knee replacement, they're going to get the same outcome, which is the highest quality in the organisation across the country in which they go to. They're going to get the lowest complication rate, and as a taxpayer, they're going to get it at the best value and a timely time. That's all patients want. And actually, patients are very grateful to the NHS, I have to say, and I think it's a great organisation. I have to say, I'm totally supportive. Why? Because I'm a consultant that works in it. I am going to be a patient one day, so I want to make sure it actually works really well. But I'm also a taxpayer, so I want to make sure it's efficient. And I've got 2 kids doing medicine. I want to make sure they have a health service they can be proud of, as I have been. And patients actually aren't difficult. Patients just want great outcomes, the right advice, low complication, and they can get on out there with their life. And there is too much variation out there to actually sit on our laurels and say it cannot be improved. We can make a massive difference within the budget that we've got. So if you said to me, if you split social care out, do we need more money? Not with where I'm sitting, I've gone to 265 hospitals, maybe we don't. There's huge waste out there that we can actually improve. And actually, if we get it right, and this will deliver this programme, I promise you, with the clinical leaders we've got. So we've just applied for 19 more clinical leads. We've had over 50 applicants, most of them absolutely top draw. And by working together across NHSI and NHSE, I work with a great team. I work with a guy called Professor Tim Evans, who's the National Director of Productivity. Fantastic guy who gets it. I work with Jeremy Marlowe, who's a civil servant, who's fantastic. And we get it. And the whole team wants to deliver it. So if you said to me, how can you help us in NHSE? 2 things. One is to help with levers, to drive the change. I know tariffs is fixed for 2 years, but when we come to you say we need some commissioning guidance out there, we need it now, and this is what we're going to do. I'd like to see an urgent response so we can drive that. And we don't want to duplicate and triplicate effort. So we're driving the GIRF programme. We're going to have all the data that can inform your specialised commissioning. CCG is already phoning us up for data and working with Muir. But what we don't want to do is have duplicate and triplicates, and sometimes I think across the 2 systems that is happening, and we need to squeeze that out. And there are teams here that are trying to do what we're doing, but we're way ahead of the game. Use that resource somewhere else and just come to us for the data. So between us, I think we can make a massive difference.
Thank you. Bruce? I was just going to ask Tim what we can do to help, but he's told us.
I'm sure there's more advice. That was powerful. So Bruce, is that okay? I'd move on to
that's perfect.
Moira.
We know where you live. That's what worries me.
You've been very helpful anyway, Bruce, I have to say. Great.
Moira.
Thanks, Malcolm. Really encouraging, positive story, and obviously necessary work. All the examples you've given us are from physical medicine, given that we aim to for parity of esteem in relation to mental health. Does your remit cover mental health, and could you give us therefore some examples in that field?
Yes. Yeah, when we're on the road, this is to do with starting with allocative value. I usually show the figures. So respiratory 5 billion, cancer 7 billion, skin 2 billion. How much do you think we spend in mental health? And then I ask the room to vote. And this would include a room with finance staff and mental health professionals. And there's silence in the room. And then I offer them 1 to 4 billion, 4 to 8 billion, or over 8 billion. And usually 80% of the room says 1 to 4 billion or under a billion. The answer, of course, is about £12 billion a year. Now, it should be more, but what are we getting for £12 billion? And it's actually quite hard to see that if you look at the annual reports of trusts, because they have got big lumps of things like adult or community, 119 million or 64 million. And we don't have a Tim working in that way at the moment. So that's the first issue, I think, is to be much clearer. I know it's more complex, mental health is more complex, but we have to apply the same principles of how much is allocated. And there's a 1.9-fold variation in what CCGs allocate to mental health. It varies from about 1.6 to 1.9 over the years, and there may be 0.1 here or there as data handling, but huge unwarranted variation. So I would see this as a key issue. And think there are certainly high value activities that could be done more of, but we have to engage with patients, the public, and the professionals to look at unwanted variation and then to look at the outcomes and the quality of what's provided. I'll give you a very simple example. I ask people, how much is spent on depression in this population? Silence. How many people are there with depression in Barsetshire? Silence. How much, then asking the specialists, how much do the GPs spend? Silence. So we need to get the map on the wall, and that's where I think the STP is the right sort of level. So we're taking this approach, and it is the most complex area, but the same questions apply.
So if I can just comment on that too, actually. So in my discussions with David Williams, the Financial General of in DH, we've agreed to appoint a national GERF lead in mental health. So I've had conversations with the President of the Royal College of Psychiatrists. We've already got a business plan together, and we will be appointing our 30th specialty, which will be mental health. At the moment, I can't give you some examples like I can in the others because we haven't done the data mining, but we know in things like rehabilitation, there's massive gains to be had in that. So watch this space, but there will be a GERF national lead in mental health.
Right, well, I think the board has had an extremely valuable insight into the work that's happening both in Gerfton and Right Care. It's quite an eye-opener, and I think you're absolutely right to present the findings as starkly as you do with the extraordinary variation. And I think your message to us, which is about allocative efficiency as well, perhaps culturally more difficult for us to absorb, is something that we certainly take on board. Can I, on behalf of the board, not just thank you for coming, but actually for the energy and the application that's gone into the work so far, and to the potential implications. And of course, the potential implications aren't just limited to what we do in the NHS in this country. These are of global significance. And of course, the Atlas comes from Jack Wenberg originally. I mean, I think this is an extraordinary, valuable insight at a time when there isn't a sustainable healthcare system in the modern developed world. So,
and we'd be pleased to speak to any individual members of the board, or like you see for your local patch where it is. So don't, you know where we live.
Well, we know where you live, but also I think the point that both you and Tim were making around the STP process as being a way of trying to take on particularly the allocative efficiency issues of this is absolutely critical. So we will not only know where you live, but we'll be knocking on your door and drawing on your expertise. So thank you again very much for the presentation. And again, thanks to Matthew Cripps and the rest of the members of the team who've been driving Right Care on our behalf. Good.